Hi everyone, my name is SiddiquiH, and today I will be sharing with you the findings of an environmental scan of health equity measurement in Canadian hospitals. I would like to disclose that I am a research associate at the Dr. NHRC Center for Health Equity, and this session has received in-kind support from Health Sciences North and the Dr. NHRC Center for Health Equity. In Canada, everyone should have equitable access to healthcare, but we still see large disparities in access. Hospitals play a key role in mitigating this, but in order to do this effectively, they have to know how to measure health equity within their programs and services. There has been some pioneering work done in how to measure health equity within the Canadian hospital context, but there is no comprehensive guidance on how to adapt health equity measurement to local hospital contexts. To fill this gap, under the guidance of an advisory group, we carried out an environmental scan of public documents from hospitals and health-related organizations from across Ontario, with an emphasis on northeastern Ontario. Our research team deductively coded these documents to extract information pertaining to 6 key health equity domains. We reviewed documents from 85 different organizations, with larger academic health science centers contributing a greater proportion of documents, whereas community-based hospitals had fewer or no publicly available documents on health equity. The diagram to the right here represents the core domains we used in our thematic analysis for measuring health equity in hospitals. At the center is the main goal, which is measuring health equity, but surrounding that are 6 interdependent domains that need to be addressed for health equity measurement to be meaningful and actionable. Our first domain is equity-deserving populations. These are subgroups who experience worse health outcomes due to marginalization or social needs. Across our scan, the most frequently referenced groups were Indigenous and Black populations, racialized groups, LGBTQ+ individuals, newcomers to Canada, Francophones, people with disabilities, unhoused individuals, older adults, and those living in rural or remote communities. In fact, Northern Ontario itself was occasionally identified as an equity-deserving region. Some organizations also define these groups by medical conditions, such as certain mental illnesses or chronic diseases. Next, we have comparator populations. Now, this is a nuanced area. Some documents caution that unless you have a good rationale to do so, it may be best to avoid comparisons that obscure inequities or reinforce stigma, suggesting that subgroup data should instead be presented distinctly. However, practically speaking, during implementation, comparisons between marginalized and majority populations are sometimes used to identify systemic disparities. Third, we have equity indicators. Hospitals are using both standardized and locally tailored indicators to track equity progress. These include sociodemographic variables like race, gender, income, language, and housing status, as well as indicators of cultural safety, patient experience, and access to services. Some hospitals are also developing indicators tied to institutional progress like EDI training, policy reform, or community engagement. For Indigenous populations, there is a push to shift away from deficit-based measures towards wellness-focused indicators rooted in culture, land, and traditional knowledge. Next, we have data sources. Hospitals are increasingly creating their own equity-focused databases using electronic medical records, surveys, screening tools, complaints, and community engagement initiatives. These local sources help fill gaps left by large administrative databases, which often exclude equity-deserving populations. When linked, social needs data can be used to evaluate quality of care and health outcomes, offering a more holistic view of equity in action. In the domain of data analysis and reporting, there's growing recognition that equity data must be analyzed and reported using standardized, transparent methods, but also through an equity lens. Hospitals are embedding this work in quality improvement cycles and using tools like equity scorecards and EDI trackers. Importantly, some organizations are shifting away from deficit-based reporting in favor of a more strengths-based approach that focuses on what's working, closing the gaps, and improving wellness. And in our final domain, we have oversight and governance. The themes underlying this domain are accountability and trust, along with emphasizing that data belongs to the people it represents. Data should be collected and governed with community leadership and consent, especially when working with Indigenous populations. Principles like OCAP should guide how data is managed and shared. Together, these domains show that measuring health equity requires much more than a dashboard. It's a systemic, context-sensitive, and community-driven process that must reflect both what matters and to whom it matters. To wrap up, I want to highlight 3 major takeaways from our work. First, there is no comprehensive or widely used strategy for measuring health equity across small, community-based hospitals in Ontario. While some larger academic centers have robust equity frameworks, smaller institutions, particularly in rural or northern regions, often lack the resources, infrastructure, and guidance to do the same. This gap presents a significant barrier to equitable care delivery at a systems level. Second, existing administrative databases need improvement. They currently suffer from a range of biases, such as selection, misclassification, and exclusion among them, that limit their usefulness. More importantly, these databases often omit the very populations hospitals are trying to serve more equitably. We need data governance frameworks that go beyond compliance to meaningfully empower communities, especially by including the voices of people with lived experience in data collection, interpretation, and decision-making. Finally, measuring health equity requires a paradigm shift. Rather than focusing on deficits or disparities alone, we need to emphasize strength-based and wellness-based indicators. These should reflect culturally safe, trauma-informed, and equity-driven models of care. This means evaluating not just clinical outcomes, but also the impacts of systems change, relationships, and healing environments rooted in Indigenous knowledge systems. Together, these 3 points call for a more nuanced, community-based, and inclusive approach to measuring health equity in Canadian hospitals. Thanks for listening, and please feel free to reach out if you have any questions.